But yeah, it's a little too simple to just say move more, I think. And Spina in his latest episode, his monologue, he was kind of hinting at that. I think he was saying, well, moving more is great, but it still doesn't home in on the specifics or the individualized issue that each person has, you know. So if you have a poor big toe that just doesn't move well, just by, going for more walks or doing more weightlifting or whatever is not going to directly change that exact joint issue.
Mm-hmm.
So, and that's really our role. I think with the amount that some of us charge for things and the amount of school we went to and the amount of, maybe, I don't know, respect that we get from our patients that think we have answers, we need to have a little bit more nuance than say move more. And I think that's where these functional or movement screens, or the origin of FMS and these type of people came from, Kelly Starrett's stuff. um, that's the other side of the ditch, I think, right? I mean, not in the sense of the far side of just move more, but trying to say, okay, let's move more. Gray Cook's famous saying of first move well, then move often is brilliant and concise, and it's a good way. It's a good way to segue into this, I would say, into the more effective method, which would be, okay, first you have to move well. So what does that mean? Before you go move often, which would be just go move more. Sometimes that just yields injuries, actually. There's many cases where you tell that, the person decides to go do yoga and they make their back pain worse.
For
It's
sure.
probably flip of a coin. It's, if you don't have a diagnosis on that thing, 50-50 if they're going to make it worse or better, in my opinion.
So, okay, got it. So now let's just take that Gray Cook, move well, then move often. Okay, what does move well mean? Does that mean have a negative Hawkins Kennedy and O'Brien slap Apley scratch test? What in your mind? Let's get into this. You mentioned to me you had a patient come in who actually, I believe most people would say, probably if they were to look at her, moves pretty well, based off of the accomplishments in their life. But more specifically, what does move well mean?
Well, I mean, I think the move well part, this, for example, Dr. Spina, who we've just been talking about, has made his entire career, or at least his business model, around that idea. And in his definition, which would be this idea of joints need to work well independently first before they can start to become friends with all the other joints in your body. So you can make complex movements possible. Each independent joint has to be robust in itself, and really hard to refute. I don't have a problem with it. I try to focus on that myself. But then, I could say, the only thing I could say is many people are not going to spend their whole lives dedicated to all their joints and making sure they move well. So at least, I don't think Spina would say that either, but I think at least we could really get to the interviewing or motivational interviewing process, where we really discover what the patient's goals are, who they've always been. If they don't plan to ever do a handstand or overhead work, it's just, maybe you got to get their shoulders a little bit better, but they don't need to have the world's greatest shoulder car or rotation and wrist flexibility and strength. So at least we can move well for that person. What does that mean for that person? Are they a cyclist? Are they a gymnast? Do they just want to walk without pain? Are they a hiker, skier, on and on and on? And I think that does matter, because most people don't have the energy reservoirs to just do whatever you say. Even if they trust you, they're out of pain. They're going to have even less of a reservoir to pull from, because nothing hurts. So I'll do something, but I'm going to go back to what I enjoy doing mainly.
For sure. So, so you're saying move well means specific to the patient's, hopefully a good history that you're taking and listening, and not, because move well for me when I first started was, I've got a bag of tricks, and I know a couple things to make, say, a hip or a shoulder work better, and I'm going to find some of these tests to match, and I abhor this, the toolbox that I have. And so I will do tests that I know I can fix, and I'll play that game. And I kind of didn't know that I was doing that at first, to be honest, but I would be like, let's find a way to prove that this shoulder is a nail, because check out this cool hammer I got. And that served me well for a little while. But in terms, let's more specifically in terms of, go ahead. Yeah.
It reminds me of, this dystopian FMS community where even Gray himself after a while was like, the point is not to become great at these tests. Yeah. Where people were just improving their inline lunge, these kind of things. They weren't actually getting better at their sport, or maybe their hip wasn't improving. But whatever input they did, they got better at those 6 tests, and that's all that matters, right? So, and Gray was saying that's not really the point. These numbers are just there for pass or fail, and then you kind of where to start. But it was never about improving the tests. I mean, nobody puts a dowel behind their back in inline lunges anyway. Right. So,
and you have to be careful as a doctor, because when you do those tests, you're conditioning your patient to be like, this is the measure for a healthy shoulder. They don't know, you know what I mean? Especially if you're doing, these couple orthopedic tests with this long lever traction, and they have their significant other test some of these isolated rotator cuff. Man, I'm not good at fixing orthopedic tests specifically. For those are ruling out pathologies for me. They don't necessarily help me get a patient better, back to our initial thing. So that said, when you do pick tests, because there are those patients that are really dedicated to what it is you're doing, you're getting them better. They trust you as the expert. And so if you give them an inline lunge with a dowel rod on a 2x4, they will get better at that. And then if that doesn't also fix, let's see, their IT band pain at mile 4, they're like, but I'm great at inline lunging. You'll see that there's that kind of disconnect. And this is going back to what you were saying about their specific issue and desire and need in life. Okay, so back to these tests. The main thing kind of I got from that Dre episode was to assess the capacity of each joint. And when we move, we have to move in one joint in relation to another. And movement would be a combination of all those joints and the interplay working together. Now, if you were to assess some of those joints, and this would, just to basically kind of run over what his test might look like, you could consider them more of a passive range of motion kind of a test of a humerus on a glenoid, to see how far that humerus could move on that glenoid independently of the whole shoulder complex, right? And so
I would say he's more active focused.
Fair. Yes. There are some passives, but that's the idea. And then once you got that passive marker, you would be able to go through some active tests, the cars, basically moving your shoulder as far as you could. And you would see the little hitches and the giddy ups as you would move your arm around. There would be little spots where it wouldn't move so clear. And that what should look like a circle has little divots in it, little bumps in the road, where that capsule is not moving clearly on the joint next to it. And so those muscles and those joints do not have the full capacity. And so you're going to call on other joints to, or muscles nearby to compensate. So for instance, he in that episode talked about shoulder flexion. And you would want to see how far your humerus can move on the glenoid before the entire shoulder complex got stuck together and moved as a whole. Right. And so he talks about specifically in some of his things, the rotation of a collarbone, stuff like that, which is some old Dio stuff, which I love the specificity of some of his manual work, which is fantastic. But seeing where you could move freely and where you would start to compensate is a very vague way to go about explaining it. So how do you, like, let's say with a shoulder test, like I'll put a person's back up to the door at head, back, and shoulders, and then they'll raise their arm up as high as they can go without, letting their low back extend to kind of show them where they're cheating with. And the better the athlete, the better the cheater. I mean, that's just kind of the way it goes. And they'll build in capacity in their extensors, in their spinal complex, without having a real shoulder that moves the way it should move. That's where I kind of start with moving well, would be a little bit more of these joint isolations. And it would still be the standard joint flexion, joint extension, shoulder abduction, stuff like that.
And the reason would be, right, I'm guessing you do that because your orthopedic tests tell you at best what specific tissue is injured, right?
Correct.
If it's specific, if it actually gets everything it's supposed to do, it'll tell you what's injured, but it doesn't tell you why it's injured or how it became injured, right?
Right.
So, that's the problem with the orthopedic testing, is you base it on this idea of we injure something, we do these tests to figure out what was injured, and then we work on that thing. We rub that thing, we needle the thing, like we've already talked about. Mm-hmm. So I think if anybody's listening and they're kind of going, okay, yeah, in my first patient visit, I'm doing a lot of pretty much just orthopedic tests. That's pretty much what I do. Then you might want to, it doesn't mean there's nothing wrong with them, and we can explain why they're valid and still useful, but you might want to think about a few tests for different parts of the body that you can start to do to maybe tell yourself more information. Things that would connect the shoulder to the spine, or the hip to the spine, foot to the knee, foot to the hip to the foot, these kind of things. So whether it's a squat or single leg squat or cars or any of these different modalities, these other type of testing styles, and they can tell you they can maybe point you in the right direction towards why they're in the problem that they're in. So it might sound simple, but I still think most practitioners are doing more simple testing or orthopedic testing, and they can say, I know what's wrong with you. You have hip impingement, and I'm going to start my process of how I treat those, which is possibly not arbitrary, but a standard model.